Good afternoon and good evening. Welcome to Global Health History Seminar number 151, Antimicrobial Resistance, AMR, Global Policy, Clinical Practice and Public Responses. I'm Dr. Suranga Dolamulla, Senior Research Fellow, University of York, Clinical Academic Fellow, York Hospital Trust, UK, and Specialist in Medical Administration, Minister of Health, Sri Lanka. Today, we have got eminent speakers from Sri Lanka and the UK. The Q&A session would lead by Professor Krishanta Veerasuriya, Professor of Pharmacology and former Regional Advisor, Essential Medicine, WHO Southeast Asia Regional Office. And the focal point of AMR in the Minister of Health Sri Lanka, Dr. Saman Ratnayaka, would be joining the session later on. This seminar lineup would be presentation by speakers, a case study discussion, and a short presentation by Dr. Saman Ratnayaka, and lastly, the Q&A session. Before introducing the first speaker, as requested by panelists, let me briefly make a little comparison between Sri Lanka and the UK in terms of healthcare financing and vital statistics for better understanding of the presentation. So, as you can see, it's really a comparison between UK and Sri Lanka from 2010 to 2019 for healthcare financing details and vital statistics. In terms of population, UK has got 3 times as Sri Lankan population, it's about 21 million. The total healthcare expenditure per GDP, it's about 10% in the UK, whereas in Sri Lanka, it varies around 3.8%. Government expenditure on healthcare is higher in the UK, it's about 78%, Sri Lanka, it's around 48%. Out-of-pocket expenditure is low in UK, it's about 15.1%, and Sri Lanka varies around 48%. And per capita health expenditure is so much high in the UK compared to Sri Lanka, it's about £3,227, whereas Sri Lanka spends a very low amount, very small amounts, about £120 per person. And when you talk about the public and private mixture about the outpatient care in the UK, it's really dominated by NHS, National Health Service. And Sri Lanka, it's shared equally between private as well as the private public sector. Even though there's a vast diversity in healthcare financing details, the vital statistics are not that much significant difference can be seen between these 2 countries. For instance, the life expectancy at birth for females, it's about 83 years in the UK, whereas Sri Lanka is 78 years. Adult literacy rate, you can't see that much of differences. Even maternal mortality rate for 100,000 live births in the UK, it's around it's about 13. In Sri Lanka, it varies around 30. Infant mortality rate also, Sri Lanka is able to manage under 10, whereas UK is low as 3.8. With this background, may I invite Dr. Neil Todd, is our first speaker today. Neil has 34 years experience of working as a clinical microbiologist in the National Health Service, NHS UK. He is the clinical director, antimicrobial lead, and the chair of Antimicrobial Stewardship Committee of the York Teaching Hospital NHS Foundation Trust. Currently, he is leading a project to create a laboratory network service covering North and East Yorkshire with a population about 1 million people. It's over to you, Neil.
Okay, well, welcome to everybody, and thank you for giving me the chance to talk through what will be a fairly pragmatic view of the problems that we face with antimicrobials in the modern world, from a very gloomy looking England today, I'm afraid, at lunchtime. Just to give a bit of context, York Teaching Hospital NHS Foundation Trust is a medium-sized teaching hospital in the NHS in England, based in Yorkshire. York's about here on the map that I've got, and we have another major hospital up on the coast at Scarborough. So those are the two main hospital sites. We are an NHS teaching hospital linked to the whole York Medical School. We cover a large geographic area with 8 hospital sites and provide a comprehensive range of healthcare services for approximately a population of 800,000 people, utilising around 9,000 staff and more than 1,100 acute hospital beds. When we think about antimicrobial resistance and the problems associated with the use of antimicrobials, I think this is not just an intellectual challenge. This is a challenge to human behaviour, and I think it shares many features with what I'm showing on these pictures, which, as I'm sure you've probably worked out by now, is another phenomenon of human origin, which is global warming. Where the actions of all of us as individual human beings sadly add up to quite a profound impact on the planet that we inhabit. And I think part of it's about getting what antibiotics and antimicrobials are into a bit more perspective than we perhaps do. A lot of people sort of view these as very miraculous drugs that have transformed human existence. And whilst they certainly are very important drugs and make certain types of healthcare activity like transplantation and chemotherapy, etc., possible, I think this slide's quite informative in that it sort of gives you a feel for actually the mortality, the morbidity mortality associated with infectious diseases over the last 200 years, well, 120 years, and shows that actually antibiotic use was introduced actually when the curve was actually already probably 2/3 of the way down. So there are a lot of other interventions that are equally important in controlling infectious diseases. It's not just all about antibiotics. I think we need to remember that. The biggest challenge, I think, for me is understanding the problems that we face. And many people's individual view of the world gives them one particular view, and it's only when you look at the bigger view, and I think microbiologists tend to see the bigger view on a daily basis more than perhaps our frontline colleagues, that you actually start to get a grasp for the scale of the issue, as this picture, so that the two pictures show. Context is everything, really. So what are the problems in using antibiotics? Well, there's a number of them, and I'm not going to spend ages on this because I think most people listening probably understand a lot of this, but they're drugs, they cause side effects in individual patients, like all drugs do. I'll talk a little bit about the microbiome and the impact that antibiotics have, because I think this is a growing area where our understanding is increasing and will probably have quite profound implications for how we use these drugs going forward once the evidence starts to come in. Bacterial resistance I'll mention briefly, we all know about that, but it's a big problem. Antimicrobials also cause superinfections. Good examples of that would be a lot of fungal infections or Clostridium difficile infection, which I'll talk a little bit about at the end of my session. Interestingly, they also increase or promote cross-infection, so they actually enhance the spread of the resistances that they cause. Having an effective normal flora or microbiome is actually quite important when it comes to actually protecting you from picking up extraneous bacteria through cross-infection, and antibiotics increase cross-infection by destroying the normal flora. And one of the biggest problems we face is that in many countries, certainly in England, many antibiotics are a lot cheaper than the diagnostic tests and the infection prevention interventions that we need to actually deal with them. So it's cheaper to actually treat somebody than actually make a diagnosis, which is a really serious problem. These problems, most patients receiving an antibiotic will sustain one or more of these whenever they receive such a drug. So you are always balancing risk and benefit when you use an antimicrobial, and it's important to remember that. And many of these effects are worsened with the use of broader spectrum drugs, longer durations of treatment, and the use of multiple antibiotics or polypharmacy. The microbiome, or what used to be called normal flora, is increasingly being understood in terms of its benefits for us as human beings and our human health. And this is just one slide indicating a range of effects for just this one of the microbiome areas, the gut, and the increasing understanding of how the gut microbes influence, either directly or indirectly, many mechanisms in our physiology. And it's becoming clear that certainly for a lot of animal model work so far, it's difficult to do this type of work in humans, that you, by manipulating the gut microbiome, you can have actually quite profound effects on the well-being of animals and probably human beings. And I think we need to understand this a lot better, because we almost certainly are causing these effects each time we treat people. Bacterial resistance, I'm not going to spend ages on. I mean, there are problems with bacterial resistance in virtually any organism and antibiotic combination you can name. I've just picked out a couple of examples here. This is so-called extended spectrum beta-lactamase production in E. coli. And you can see globally varying levels of problem with this, with very high levels in certain parts of the world, but virtually all parts of the world now afflicted by this type of resistance, that at a stroke with a plasmid, often plasmid-borne enzyme that destroys a range of beta-lactam antibiotics, you can lose about half of what it's taken us 70 years to produce as antibiotics. And many of these enzymes are simple point mutations from earlier very common beta-lactamases like TEM, SHV, and CTXM. So we can spend years producing a new antibiotic, and an organism can find a way around it in relatively short order, and that is a real challenge. This is another form of enzyme-mediated resistance causing carbapenem resistance, in this case in Klebsiella pneumoniae as an organism. And again, you can see, unfortunately, red and dark red areas of the world already where these sorts of infections are becoming increasingly common. And again, this type of resistance can be plasmid mediated and spread very quickly. That's a simple picture illustrating the scale of the problem that you face often with carbapenemase producing organism. This plate showing a very sensitive sort of organism. I started in the mid-1980s. When I started, most of the things we grew from patients looked like that, with multiple sensitivities to multiple drugs. And this is a CPE, or carbapenemase producer, with very few options, this same range of discs. So again, losing many of the things it's taken us years to produce. This infographic's taken from Lord O'Neill's report, which was produced, I think, around 2015 in the UK, which was an attempt to look at a national level and international level at the impacts of antimicrobial resistance and project that forward into the future if we didn't change the trajectories that we're already on. And this is looking at global mortality from different conditions, projected out to 2050, and actually suggesting that infectious disease might yet again, or once again, become the preeminent killer of human beings if we don't find ways to address this problem of resistance to antimicrobials. And even at the moment, a global estimate here, which is obviously with large error bars around it, but still 700,000 deaths per year globally from resistant infection already. So what is antimicrobial stewardship? It's what you make it to a certain extent, but I would best describe it as a multifaceted, multidisciplinary approach designed to ensure that antimicrobials are used in a way which maximizes their benefits, prolongs their utility, and recognizes fully the harms associated with their use. And the expectation would be that any institution or organization where antimicrobials are being prescribed would have a group and an approach at institutional level. And that's certainly the expectation in England, that there's a requirement of all hospitals, primary care practices to have an antimicrobial group and an approach to this problem. The key components of this type of scheme include developing policies. I'll talk a little bit about that. Education of users, including patients, surveillance of problems, including root cause analysis of adverse outcomes like C. diff, which I'll talk about towards the end. Auditing compliance with the policies. No good having a policy if people don't follow it. And developing campaigns to start to influence behaviours around use of antimicrobials. And the key facet is you really do need to find a way of gauging everyone, including ultimately the patients in this. And that is a big challenge. So what have we done in England? We started with awareness raising, and we had some fairly large scale reports done. The House of Lords did a good report in 1997, and the O'Neill report I mentioned 2015, to try and understand the scale of the problem that associated with use of antimicrobials. We then moved on in the early 2000s to targeted interventions to incentivize improved performance. And we had one for MRSA bacteremias, because England and UK found itself in an unenviable position of being one of the worst countries in Europe for MRSA bacteremias in 2003, 2004. And then a further program looking at C. diff, and I'll talk about the C. diff one in a bit more detail in a minute. CQC was set up as a way of trying to drive up standards of care in NHS hospitals. And they were given responsibility to oversee some of the regulation around inspection of services, to see that we were actually complying with this piece of legislation that was launched in 2008. And that actually includes a code of practice that covers antimicrobial use. So that basically lays out how we should be trying to do that, and then inspection of that process. So it is quite heavily regulated in the NHS. We've got a national antimicrobial resistance strategy I mentioned briefly, and we have got increasing levels of national level guidance, including a pathway process called Start Smart Then Focus. I've got a picture covering that. And our NICE, which is our National Institute for Health and Care Excellence, producing guides for actually treating common infections, to try and guide people how to address the issue of antimicrobial use. 5-year UK strategy, the latest iteration, we're on the second 5-year one now, there was one in 2014, takes very much a One Health approach, so it's covering human and animal use and environmental factors. We have some hard targets in this strategy to reduce drug resistance infections by 10%, which is around 5,000 cases a year by 2025. Reducing human consumption by 15%, reduce healthcare acquired infections by 15,000 by 2024. and reducing animal use of antimicrobials, which is making some progress. I think the next staging post was supposed to be this year, although that may have got derailed by COVID. We're also looking to improve real-time data on antibiotic use and outcomes with linked usage and laboratory outputs in terms of organisms that we're isolating from our patients and trying to match those up in real time increasingly. And then looking at new payment models that don't stress making profits in pharmaceutical companies purely on the quantities of antibiotics sold, but actually look at what value a treatment adds to a patient's care as a way of funding it. This is the Start Smart Then Focus pathway, which is very much a guide to how you start antimicrobials, some of the important factors, and then the process for once you've started actually reviewing and going around the cycle repeatedly of checking whether you still need to carry on with an antibiotic once you've started one, accepting that at the beginning there may well be a certain degree of uncertainty around the presence or otherwise of infection. And this is an example of one of the NICE guidelines. This is for acute sinusitis and how to use antimicrobials, or in many cases not use antimicrobials, particularly in primary care settings, a general practice, where we know that many of these infections are non-severe and viral in nature, and trying to guide people to understand that the importance of not giving antibiotics in that sort of situation. So what we've implemented our antimicrobial stewardship program in our hospital in the following broad way. It started in one hospital, but is now developing across much larger footprints covering geographical areas. We've got a North Yorkshire antimicrobial stewardship group now to try and spread this message on a broader basis. It's very multidisciplinary, with lead roles in microbiology, and we've had lead pharmacy roles in antimicrobial stewardship since the C. diff package in 2007, 2008, which has been crucial in driving this initiative forward. And we then try and find people in all our main clinical services who will act as what we call antimicrobial stewards and be the focal point for a frontline clinical service. And we're very much working now to try and devolve a lot of the activity to the front line, as opposed to the very central sort of antimicrobial stewardship group that we perhaps had historically, because the action's really at the front line with all the individual decisions to use antimicrobials. It meets every 2 months, and as I say, we oversee our strategy and support our stewards, and we are starting to think about how we can involve patients directly in this process more than we do at the moment. We have a number of local antibiotic policies. These are our attempt to integrate national guidance with our experience and the ecology of our hospitals, and ecology can vary quite a lot between different NHS hospitals based on history of antibiotic use. They're very much developed with our stakeholders in the relevant specialties, because that's how we get uptake and use by ownership. We identify good practice in diagnosis within these policies to try and guide people how to use the laboratory effectively to make better diagnosis and more accurate use of treatment. And we also have very strong principles around reducing use of higher risk antibiotics, which originated from our C. diff national package, which included the so-called 4C agents, that's cephalosporins, coamoxiclav, clindamycin, and the quinolones, which was represented by ciprofloxacin as a C, and other broad spectrum antibiotics, and we've been very successful at reducing those and our C. diff, as I'll show you. We very much encourage early oral switching, because that tends to take you to lower risk, narrower spectrum drugs. We all very much specify our durations of therapy, because shorter durations mean generally less problems. And we are looking at how we can introduce more diversity in antibiotic use. hospitals traditionally have had workhorse antimicrobials, which get used for everybody. And I think we now understand that's probably the worst possible way to use antimicrobials in terms of selecting for resistance. I'll talk a little bit about what I do and my colleagues in clinical microbiology in England. We very much direct our laboratories, so they are medically led, and they're designed to try and help guide antimicrobial therapy in what they do. We very much spend our time liaising with frontline teams. Some of that's telephone based, a lot of it's attending meetings, multidisciplinary team meetings or ward rounds as they used to be called, and also running antibiotic ward rounds where we go around the wards and actually select patients with particular types of script and challenge the usage. We look at our surveillance of what we're getting through the lab and summarize resistance rates. We are a core member of the infection prevention team as well, because you can't divorce infection prevention from stewardship. The two go hand in hand. And we feed into our formulary and committees within the hospital to ensure that all the drugs that we feel are appropriate for use as antimicrobials are on our formulary. The key thing here is really you've got to be highly visible on the front line to have influence over colleagues who are struggling with the uncertainties of frontline clinical practice. The microbiology lab itself can support stewardship in a number of ways. It's very much about providing guidance around effective sampling. So what's a good quality sample and what we shouldn't be sending at all, and processing, because just doing microbiology on everything that comes through the door can lead to a lot of misleading and misguided attempts at using antimicrobials. We do certain level of rapid testing. You can get some quite nice results on pus samples from joints and other deep sites just by doing a simple gram fill and telling people what the organism that's present in the pus is, and that could switch a broad spectrum to a narrow spectrum treatment. We have very much structured processing of samples. We don't work up everything we grow. We only work up pathogens or things that we think are likely to be pathogens. And we test our antibiotic sensitivity based on the drugs we have available in the local formulary, not every antibiotic on the market. And we guide people to the formulary choices by only selectively reporting those that we want people to use.
Neil,
we do comment on yeah, okay. The C. diff situation in UK, the package arose, the bundle approach that was used to try and improve quality because of this rising tide of C. diff. We got up to a peak of around 55,000 cases a year of C. diff in England. The bundle was very much based around an quality improvement approach. So the main elements of the bundle were isolation of cases, improving hand hygiene using soap and water, PPE use, key one, strengthening stewardship and reducing the high-risk antibiotics, and improving cleaning. It was backed up by financial targets. So there were both incentives and penalties in this scheme. And the impacts were quite impressive, I think. So we did actually reduce our cephalosporin use. This is 2010, 2014 with a significant reduction. And this is the impact on C. diff cases, rate per 100,000 population. This is all cases, community and hospital. This is the hospital. See, fantastic reductions. So I'll finish with this man, which is Alexander Fleming. He realized very quickly that there was a problem with antimicrobials. So these problems that I've been talking through are not new, and came up with his view that everybody that uses an antimicrobial has to bear in mind the impact on others who may be the victims of the resistant organism that first course of treatment has caused. So this is a complex dynamic. And I think this summarizes the sort of broad-ranging scope of an antimicrobial stewardship approach and the roles that many people have to play in this.
Thank you, Neil. It's a good presentation. So if you have any questions, the audience or the viewers, if they have any question, we can answer. Otherwise, I can introduce the second speaker, Anita Chalmers. She has over 30 years experience as a clinical pharmacist and the lead antimicrobial pharmacist at the York Foundation. Main areas of work involve ensuring the effectiveness and safe prescribing and administration of antimicrobial while minimizing antimicrobial resistance. Anita, it's over to you.
Thank you, Saranga. Today, I'm going to speak to you about the different ways that the clinical pharmacist tries to engage with prescribers to help to support them to improve their antibiotic prescribing whilst maximizing efficacy and minimizing antimicrobial resistance and side effects. The background of my work stems from the National Action Plan, which Neil spoke about in a bit more detail. I'm on the third slide, and that summarises the main tools that are used for engaging prescribers with patients in both primary and secondary care, and this will be the main focus of my talk. Next slide, please. In our health system, GP practices have contracts with clinical commissioning groups to provide NHS services. As part of that, the Department of Health provides an oversight framework for clinical commissioning groups to engage with GP practices. This involves financial penalties for the clinical commissioning groups if targets are not met. The commissioning groups and Public Health England provide data on antimicrobial prescribing to GP practices. In primary care, the vast majority of prescriptions are issued via the NHS. When these prescriptions are processed, the data is collated in a national database which does not have any patient identifiable data, only the drug, the strength, the total quantity issued, and the GP practices are recorded. This data is then published on the Public Health England Fingertips website. For antimicrobials, the data is provided at practice level as the total number of antibiotic items per star PU. The star PU denominator is a specific therapeutic group, age and sex-related prescribing unit, which allows the comparison of different therapeutic groups according to the demographic profile of the GP practice. The data can be aggregated from practice level to commissioning level to regional and eventually national level. This data as it allows benchmarking between practices and behaviour of GP wants to be the worst, most badly performing practice. The data allows monitoring of trends in antimicrobial prescribing and reflects the impact of interventions. However, the downside is that it is not prescriber specific, which allows individuals to avoid taking responsibility for their own prescribing. Next slide, please. In West Yorkshire, their research and development group developed a piece of software which can data mine the GP practice's computer system. This data is then used to provide reports with prescriber-specific feedback. The prescribers are given individual feedback on whether they're following the antibiotic formulary in relation to choice, dose, frequency, and duration. Prescribers have to take ownership of their prescribing, and there's no room to hide behind their other partners. The practice reports are sent as paper copies, but are also available via an electronic portal. The reports benchmark practices against their peers and provide short, actionable messages, followed by more optional, detailed evidence and recommendations. They include an action plan, recent evidence and guidance, as well as statistics on antimicrobial resistance. The reports have been focused on different topics, which include overall consumption, treatment of UTIs in the over 70s, prescribing of core amoxiclav, COPD rescue packs, which will basically repeat prescriptions for antimicrobials, and for patients with upper respiratory tract infections who have received antibiotics. Next slide, please. The reports are sent to the practices every 2 months and are discussed in a practice meeting where participants are encouraged to support each other and develop and implement action plans. This helps prescribers to feel that improvements are under their control. The project was initially started in February 2019, so they managed a whole year before COVID, and overall this led to a 1.6% reduction in the numbers of patients receiving prescriptions for antimicrobials. Next slide, please. On many occasions, patients approach their GPs with self-limiting infections. The Royal College of GPs have compiled a series of aids to support GPs during consultations. These patient information leaflets are designed to share with patients during consultations with the aim of facilitating communication between prescriber and patient, as well as increasing the patient's confidence to self-care. This is an example of a common infection self-care leaflet, and there are other leaflets aimed at more specific infections such as urine and skin infections. When I worked with GPs, one of the key things that struck me was that they often felt pressured to prescribe antibiotics for patients with self-limiting conditions. This really made an impression on me, and I realised how important it was to try and engage with the general public to improve their prescribing, their understanding. As a result of this, we developed the Moxie Malone Antibiotic Detective campaign. This was aimed at teaching people the difference between bacterial and viral infections, so they could understand why antibiotics are of no use if you have a viral infection. We produced patient information leaflets which we made available not only in GP practices and community pharmacies, but also in libraries and sports centres. We had both posters placed in buses as well as advertisements on TV and radio. 6 weeks after the campaign, we followed it up with a focus group to see if the public could recall the campaign and its messages. The public did have good recall of the campaign, and this was reflected in an absolute 5.8% decrease in the primary care of antimicrobial consumption for that year. Next slide, please. In secondary care, the hospital trusts have a contractual target of reducing their total antimicrobial consumption by 1%. The data is extracted from the hospital pharmacy computer system and is based on what is supplied to wards and departments, not what is actually administered to patients. This data is collated nationally and is again made available via the Public Health England Fingertips website. Again, the data may be aggregated from individual hospital level to regional and national level. The metric used for antimicrobial consumption in secondary care is DDDs per 1,000 bed days. The numerator DDD, defined daily doses, is defined by the WHO as the assumed average dose of a drug for its main indication. As drugs come in different strengths and are used in different proportions, the DDD may not reflect an actual dose. The advantage of this is that all antimicrobials can be considered together. This allows for benchmarking and the monitoring of interventions. This slide shows York alongside the other trusts in the region and is focused on 3 metrics: total consumption, carbapenem prescribing as a very broad spectrum antibiotics. The paler the purple, the better the practice, and lower is regarded as better. Obviously, this is not qualitative. The last metric is the percentage of access antibiotics compared to the Access Watch Reserve antibiotics from the WHO categories. That the higher the percentage to 60% is regarded as good practice. Next slide, please. As we do have our antibiotic formulary available on our intranet as well as posters. However, we have been able to incorporate it into our electronic prescribing system. We use order sets which match our formulary, and these include suggested choices and agents for specific indications. We also use order sets to help manage high-risk medications and antimicrobials such as vancomycin. This slide shows the loading dose of vancomycin. A recent audit has shown that 83% of vancomycin loading doses prescribed with an order set were correct. This compared to only 62% which were prescribed without the order set. This was even more impressive for the prescribing of the maintenance dose, with 94% being accurate using the order set compared to 75% prescribed without it. This in turn helps the patient to achieve their target range in a shorter period of time, impacting on the length of stay. New slide, please. Back in 2013, the Department of Health introduced a campaign, Start Smart Then Focus, which aimed on getting the initial empiric choice right and then following up with a review at 48 to 72 hours to make an antimicrobial decision. We were good at getting the empiric choice right, but not so good at the reviews and documenting a clear antimicrobial decision. In response to this, Oxford University developed the Antibiotic Review Kit, or ARC. Originally, ARC was designed as part of a trial developed and run by infection specialists and other clinicians, pharmacists and nurses in Oxford and Brighton. Initially, York participated in the trial starting in June 2018. At our initial baseline, only 10% of antimicrobials stopped at the 48 to 72 hour review. This was consistent with the national stop rates. The ARC Antibiotic Review Kit is a system which comprises of a decision tool, patient information leaflet, and regular audit and feedback. Next slide, please. One of the key things that ARC challenges is the issue of the prescribing review and helps to support prescribers' reluctance to stop antimicrobials started by other prescribers. The ARC decision tool is incorporated into our electronic prescribing system so that whenever an antibiotic is prescribed, the prescriber has to choose whether the patient possibly has an infection, i.e. infection is not the most likely diagnosis, or probably has an infection. Infection is the most likely diagnosis. This conveys to the person reviewing the antibiotics the certainty that the initial prescriber had that the patient had an infection, and helps to overcome the traditional mindset where the reviewer has to justify stopping an antibiotic to justifying continuing an antibiotic. Staff are provided e-learning or live training sessions on the use of ARC at induction for the audits in September. We have involved junior doctors in the audits as they can champion ARC amongst their peers. The data is compiled into reports and brief posters which shows the stop rates for the previous month along with the performance of other wards. This is fed back to prescribers by email and by posters on the ward. After the introduction of the tool, the stop rate increased from 10% up to 25 to 30% and has remained at this level of consistency. We would like to see more IV to oral switches, and this will be the next piece of work that we campaign on. Next slide, please. Education is extremely important. Last year, we developed a campaign to improve the diagnosis of UTIs in the over 65s. We focused on a simple educational tool for both junior doctors and nurses, teaching them that using dipsticks in the over 65s lead to an overdiagnosis and treatment of UTIs. The presentation was made into a laminated handout which team leaders presented as staff safety briefs. This work was supported by posters everywhere, including in the lifts, on the back of the toilet door, and screensavers on computers. Over 90% of the staff working in the emergency rooms and admission wards received this training. Next slide, please. This graph demonstrates the reduction in the use of antimicrobials used to treat UTIs. The work was focused in two care groups. Care group 1 had a 42% decrease in their use of antimicrobials, and care group 2 had a 60% decrease in their consumption of antimicrobials used to treat UTIs. We would like to improve the taking of urine samples prior to treating UTIs, and we are just about to start an improvement project on that topic. Next slide, please. I hope you've given you a flavour of how we use metrics, electronic prescribing, audits and education to engage with prescribers and the public to tackle the overzealous use of antimicrobials, which hopefully will then impact on antimicrobial resistance. I'm very aware that this is a whistle-stop tour of the tools we use, so I've included my email if you would like to contact me for further information, and I've also included some links to websites relating to the topics I have been discussing. Thank you.
Thank you, Anita. May I invite the next speaker? She's Shirani Chandrasiri. Shirani is a consultant microbiologist at Chalmers South Teaching Hospital, Sri Lanka, and she has been there for the last 17 years. She is the immediate past president of Sri Lanka College of Microbiologists. Out of all her tasks, she is currently a member of Board of Study in Microbiology, a member of Technical Task Force for COVID-19 in Sri Lanka, and she's the college representative for National Medicinal Regulation Authority for Medicine Evaluation Subcommittee. Shirani, can you make your presentation now?
Previous speakers have told antimicrobial resistance is a global problem. We can't escape by being in Northern Hemisphere or Southern Hemisphere. Sri Lanka is a low middle income country which provides free universal health care to all its citizens. Our healthcare services are arranged in a decentralized pyramidal system where national hospitals and tertiary care hospital at the apex and primary care at the base level giving by rural health units and dispensaries. Extent of antimicrobial resistance in Sri Lanka. Our first almost national level surveillance was conducted by Sri Lanka College of Microbiologists in 2009, involving 3 provinces and 7 main hospitals in Sri Lanka. And at the time, we did not detect any carbapenemase producing E. coli or Klebsiella species from the blood in 2009, but the situation has changed. This is a slide actually from one of my friends who reported her antibiotic resistance in 2010 and 2013, comparing the increasing levels of resistance. You can see even the blood culture isolates of E. coli and Staph aureus resistance to methicillin are going up. This is from our hospital. After a carbapenemase producing outbreak in our special care baby unit, we started doing antibiotic consumption and resistance survey every year. Actually, we don't do it according to the standard daily dosing. We do according to the number of vials issued by the pharmacy. Even with that, this is the outcome. Every year we present our findings to the pediatricians and neonatologists, and this year we presented this to our clinical society, and they judged this as the best oral presentation, but I don't know whether they took the message antibiotic consumption and carbapenemase resistance, the vicious cycle. We have certain regulation at place. Antibiotic sign schedule 2B, that means we can, only the registered medical practitioner can prescribe antibiotics. However, we have high antimicrobial resistance due to misuse and overuse of antibiotics. This is mainly by the prescribers. We don't have any control on prescription. No auditing system, no clinical pharmacist in hospitals, and laboratory support is not timely. Though over-the-counter selling of antibiotics is prohibited, law enforcement is difficult due to shortage in manpower. We have developed empirical and prophylactic use of antimicrobials national guidelines in 2016 with all the professional colleges. However, adherence to the guidelines by prescribers is poor. There were 1 or 2 small audits in certain hospitals, and we realized the adherence is not even up to 50%. Sometimes when in the GP practice, they start antibiotics on patient request. These authors compared knowledge in pharmacy students in Australia and Sri Lanka. And you can see our students are far behind their Australian counterparts. This is a problem because inadequate awareness and understanding on antimicrobial resistance among public and healthcare workers give rise to increased consumption. They don't question why I'm given this prescription. No island-wide surveillance system of antimicrobial resistance. Most of the hospitals have WHONET and they enter data, but this is not regularly analyzed and given a feedback to the prescribers. Problems encountered in establishing island-wide surveillance are lack of central control in most places, inadequate, unequally distributed laboratory facilities, limited facilities for laboratory information systems, and inadequate human resources. Global Action Plan on Antimicrobial Resistance was launched in 2015, and according to this, member countries have to develop their national action plans. So in Sri Lanka, we developed this action plan, National Strategic Plan for Combating Antimicrobial Resistance 2017 to 2022 according to One Health approach. Mission and vision. Minimize the development and spread of antimicrobial resistance using One Health approach. Mission to promote infection prevention and control, to promote rational use of antimicrobials, and to ensure the availability of safe and effective antimicrobials of good quality. This was modeled on WHO AMR strategies. We used One Health approach, veterinary section contributing to development of the National Strategic Plan. However, we haven't included the indicators for monitoring that, and there was no midterm evaluation to see whether we are achieving the targets. Challenges faced by Sri Lankan healthcare system for combating AMR. We have limited infrastructure facilities and testing capacities. Microbiological diagnostic facilities are limited up to the base hospital level. There's no way that primary healthcare system can send samples for microbiological investigations. Then the problems encountered in keeping with quality and standards. We have availability of microbiologists, but like 1,100 bed hospital is covered by single microbiologist. Only the national hospital has 2 microbiologists for 3,500 beds. So the microbiologists are overworked. Lack of trained human resources. This is a limiting factor for expanding services. And whatever the available human resources are not equally distributed because of the trade unions' influence. Human resource shortage to enforce Cosmetics, Devices and Drugs Act. Uncontrolled use of antibiotics due to misuse and overuse, and over-the-counter issuing of antibiotics, lack of control over prescription, unauthorized use of antibiotics, poor awareness between healthcare workers and public. We have introduced red light antibiotics in 2017. In government sector, microbiologists do control these antibiotics, but this is not respected in private sector or wherever a microbiologist is not present. Carbapenems are not in red light antibiotics. They are prescribed for weeks without microbiology review in most hospitals. This paper by two UK authors recognized the problems in countries like us. So they have stressed that the choice of an antibiotic is dependent on the drug's cost and affordability to the patient. This is particularly important if a prolonged course of antibiotic treatment is necessary. This is for low resource hospitals like our setting. Challenges we face. Quality failures in antibiotics undermine the faith in clinicians. So polypharmacy is common. They prescribe more than one antibiotic thinking one will work. We don't have post-marketing surveillance. So whether the quality is still there, we don't know. Access to microbiological diagnostic facilities is not uniform in the country. It's more concentrated in developed provinces than outstations. Sri Lanka is not submitting data to WHO antimicrobial consumption surveillance. However, we have some achievements. Strict control has safeguarded the sensitivity of sulfadoxine pyrimethamine, and malaria is eliminated from Sri Lanka. Rifampicin is another drug under strict control. This contributed to low multi-drug resistant rates in TB. We have shown that strict control, enforcement of regulations can control resistance. Antibiotics as growth promoters are no longer used in animal husbandry. This map shows that we have started providing AMR data to WHO glass surveillance. However, you can see we are not providing antimicrobial consumption data to WHO yet. Future. Countries started submitting data to global antimicrobial surveillance system through 17 surveillance laboratories. And we have appointed our AMR focal point. Hopefully, Fleming Fund grant will give a diagnostic facility improvement to these 17 labs. Post-marketing surveillance is planned to start in 2021. Primary healthcare package, which is planned at the moment, will improve access to better diagnostic facilities. It will arrange cluster training to an apex hospital, giving microbiological facilities to our base, that is rural hospitals and dispensaries. Country has introduced quality indicators to the government hospitals. These three: Staph aureus bacteremia rate, compliance to hand hygiene in special care units, and cesarean section infection rate are monitored. However, we don't analyze this and give a feedback. We need to start these things. Reduce the incidence of infection through effective sanitation, hygiene, and infection prevention measures. One main goal in our national strategic plan. All main public and private hospitals have separate infection control units. In government sector, this plays an active role in controlling hospital-acquired infections. We have big overcrowding, and in this situation, infection prevention is one important challenge. This article, written by a UK medical student did elective appointment in southern province Galle during the war-torn Sri Lanka, recognized the importance of certain attributes in Sri Lankan system. He concludes that even with overcrowding, that our system is giving a reasonable service. When I was searching for our presentation, I came across this from a young microbiologist. She has written this note And in that, I saw this. I enjoy my work with the challenges facing me, with the limited facilities we have here. Using the knowledge and experience gained in Manchester, I am trying to do my best to develop my local microbiology diagnostic facilities. This is our strength. Our well-trained leadership will take the AMR control to another level if the support is given from the higher up. We never had anything like coming it from the political level to the ministry, equal to something like your Lord's Assembly giving directions. So I have some hope for the future because young microbiologists are coming and taking up their positions with the hope of bringing some difference to the country. I will finish it with this. The only good is knowledge and the only evil is ignorance. Thank you.
Thank you, Shirani. It's a really good presentation. And may I invite Anita Chalmers to present her case study now.
First of all, I'd like to introduce you to Betty, who is our patient. She isn't a real patient, but a compilation of the sort of things that crop up in our hospital. And as for her medical teams, well, I'll let you decide for yourself. Next slide, please. Betty is a 72-year-old female with a 2-week history of increasing shortness of breath, cough, tiredness, night sweats, and a history of hypertension, diabetes, ischemic heart disease, and mitral regurgitation. Next slide, please. This is her initial clerking. As you can see, her examinations and investigations are summarized here. And of particular note are her normal body temperature, her respiratory rate, the bibasal creps, and X-ray confirming shadowing on both lungs. White cells are normal, and there's a modest rise in her CRP. So next slide, please. The question I would like the junior doctors to be asking themselves are, does this patient have an infection? What is the source of the infection? What samples do I need to send? And if she needs antibiotics, what would be the indication? So I'd like to introduce you to her medical teams. We have Team A and Team B. Next slide, please. The A team decide that congestive heart failure is the most likely diagnosis, and note that Betty is not septic. However, they do take blood cultures as well as urine and sputum samples. They treat her with diuretics and start a fluid balance chart. They don't start antibiotics, but do monitor her for signs of a deterioration. Team B diagnose heart failure, but are concerned that there might be an infective element. So they document query chest infection, but cannot exclude a UTI due to the dipstick result. They forget to order samples, and they start diuretics, but they feel that they should cover her with piperacillin tazobactam. Next slide, please. By day 3, Betty is stabilizing. Team A are treating her for heart failure and receive the results from the samples they took, confirming that she does not have an infection. Team B continue treating her for heart failure, but they can't review the results because they didn't take any samples. They do make an IV to oral switch to colmoxiclav, but reset the clock on course length so that Betty will receive a prolonged course of antibiotics. Next slide, please. Under Team A, Betty continues to improve. However, the nurse notices that the catheter bag is rather cloudy and there's quite a strong smell. So she asks the consultant, should she do a dipstick? And the consultant says, well, no, because the patient has a catheter, she's likely to be colonized with bacteria, so there isn't any point in doing that. We should just only treat if she's got symptoms. Under the B team, Betty's not doing so well. Her temperature, she started to deteriorate and her temperature is raised. Her heart sounds are worse. her abdomen is distended. They think, well, she's not improved on Pip/Tazo, we better escalate treatment to meropenem. And at this point, they do remember to send samples. Next slide, please. Under Team A, Betty's continuing to improve, but under Team B, things are not looking so good. Blood cultures are back suggesting gram-positive cocci, presumably MRSA from the cannula site. Betty still has a raised temperature, persistent tachycardia, so they decide to start vancomycin. Next slide, please. Under Team A, she's doing well. She's almost ready for home, and preparations are starting to be made. Under Team B, Betty continues to deteriorate, and now she has diarrhea, possibly C. diff. Her heart failure's got worse, and severe mitral valve regurgitation shows on her echo. She's still febrile, and her bloods are worse. The team decide to send her to the high dependency unit. Next slide, please. Betty goes home under Team A, but under Team B, her renal function deteriorates further. She has further sepsis, worsening heart failure with cardiogenic shock, and C. diff is confirmed. She is sent to ITU, where an echo shows vegetations, leading to a diagnosis of MRSA endocarditis. More antibiotics are added. Under Team B, she's not making any progress on ITU. She's not fit for surgery, and now 3 more patients on ITU have C. diff, so an outbreak is declared. Next slide, please. Under Team B, they have the blood results back from blood cultures taken a few days ago, confirming that she's grown VRE. The team discuss withdrawing treatment with Betty's family, and she passes away later that evening. So let's review the medical team's performance. New slide, please. Team A did not overdiagnose sepsis. They organised taking samples to aid decision making to help support reviews. They interpreted results correctly and made sure they treated the patient and not the results. Next slide, please. Team B did, in contrast, overdiagnose the sepsis, leading as well as continuing treatment unnecessarily. They didn't take samples in a timely manner, and there was the use of ultra-broad spectrum antibiotics, leading to C. diff and the selection of multi-drug resistant bacteria. As you can see in this case study, it's an exaggeration of the types of issues we encounter in York, and we are trying to develop campaigns and education to raise awareness and eliminate the problems associated with antimicrobials. Thank you very much. So it's slightly tongue-in-cheek, but I hope it makes the points that, the kind of things that go wrong when we're a bit overzealous with antimicrobials.
All right. My question is, now the Team B approach was a failure. They have started antibiotics without doing a blood culture even. I think that is the reason. But how can we really understand, how can we really assess this type of failures in a normal hospital setup? Is it from a medical or a clinical audit or some other way?
I think this kind of problem lends itself to a quality improvement project where people go down and actually follow real people about their practice and actually map out the processes that people go to. And there are different people involved in this. The doctors will be doing the diagnosing, will be doing prescribing, but there are also staff involved in taking blood cultures. And I think we have to understand how those teams work together. And so we need to study in detail and look at the barriers of practice to systematically improve that. So we're improving the systems. We're creating a pathway where we take away barriers. And I've actually been working a great deal with our ED department looking at that, even to the point of making sure that we have cupboards with labels of all equipment and antibiotics that are needed to make that a very slick and smooth process. We've introduced using flags to denote that the next step in the process is needed, so that people have that clear communication and interaction. And we've been working on that for probably about the last 2 or 3 years. We have made some improvements in, say, taking the blood cultures, but we still have room for improvement. But I'm really quite proud of what we've achieved as a team so far.
Okay, thank you, Anita. So, Professor Krishant would be able to take over the Q&A session, and Dr. Saman Ratnak also waiting for his.
Yes, I will take over. Now, to start this discussion, I'll just take a few minutes to go through the 3 presentations and say, what is it that sort of came up in there, which will be useful for the discussion. Again and again, in the discussions from Neil as well as Anita, what came out was the fact that there was a system in place. I mean, at times incredibly detailed, where you looked at the system and they were able to provide feedback on what antibiotics were being used to the people who were prescribing. So they saw what they were doing. There was an overall incentive structure. There were financial incentives if you did not do, if you did well, and financial penalties if you didn't do well. So the bottom line is there was a system, the system monitored, and therefore made sure that the results came about. If you look at Sri Lanka, as mentioned by Dr. Chandrasiri, there is an overall plan, but unfortunately, further down in the implementation, we do not see an effective implementation. Even when the data is available, it is difficult to share it. Partly because I suppose we depend a lot on still the manual this thing. The UK just plucked the data out of IT systems and provide it, whereas in Sri Lanka, it is still on paper. So to me, what came out from these is the most important thing is to have a system in place. But also there are practical problems. Yes, there is a system somewhat in the government sector in Sri Lanka, but the private sector is separate and there is no system at all. Is it all doom and gloom? Not necessarily, because Sri Lanka to some extent was able to eliminate certain diseases by a concentrated campaign. For example, we have eradicated malaria. We do not have polio. We do not have childhood illnesses, simply childhood vaccine preventable diseases, because our vaccine system is good. That's because the government system has a method of going about it. Malaria was treated in government hospitals, not in private sector. Filariasis, mass drug administration, eradicated. But when we look at antibiotics, you can ask the logical question. We did this with malaria, we did this with filariasis. Why can't we do it with antibiotics? And the issue there is it is much more complex. The system does not exist to do all this. There is a significant proportion that we have from the private sector. And therefore, what we need is an overall system. And that is when we can make some significant gains. Until then, It has to be small steps trying to achieve what we want. Just overall comments on what we have observed. And now over to Dr. Saman Ratnayaka for comments from his side. Go ahead, please. Dr. Ratnayaka, you could unmute yourself and come on video. Yes. Are you there, Dr. Ratnayaka?
Professor Krishant, I think until Dr. Ratnayaka comes to the system, we'll be able to conduct the Q&A session.
Okay. Would any of the panelists, do any of the panelists have questions that we have? Because at the moment, I'm looking at the chat. We haven't got any specific questions yet, but there are those of you who are listening on YouTube. Could you give any questions that you think would be useful for you? Dr. Ratnayaka, you are on video. You want to unmute? Okay, go ahead. Yeah.
Yeah, what do you want?
Yeah, just
your comments from a Sri Lankan perspective.
Yes, of course. Thank you very much for providing opportunity, because that's a focal point of Sri Lanka. As we all know that antimicrobial resistance, one of the greatest public health threats to the entire world faced today. Therefore, Ministry of Health Sri Lanka has been working with the global effort to combat antimicrobial resistance, and one of the major initiative was the development of national strategic plan for combating antimicrobial resistance in 2017. This consists of 5 major objectives, which are awareness creation and surveillance, infection control and prevention, antimicrobial stewardship, and motivating for researchers. As a focal point of combating antimicrobial resistance Sri Lanka, I consider the implementation of those strategies of extreme importance with other sectors such as agriculture, veterinary and fisheries and environmental sectors. Since 2017, there have been many actions taken by the consultant microbiologists in Sri Lanka. They have conducted island-wide program on antimicrobial awareness and infection control, many programs. Also, we have established surveillance system on antimicrobial resistance, which focuses on determining the burden of AMR for selected bacterial pathogens of public health importance in Sri Lanka by using 24 government hospital laboratories. For these purposes, it was set up with the technical and financial support with World Health Organization. And it is actually organized in such way that is to extract required data from already established laboratory generated data system in the hospital of Sri Lanka. Another important initiative was introduction of traffic light system established in 2017 to provide guidance on choice of antibiotics to be used in specific infection. At present, in Sri Lanka, there are about 45 consultant microbiologists working in different level, like tertiary care hospital as well as few secondary care hospital. They are the main pillars, they are the main focal point for implementing those strategies in Sri Lanka. And I think all strategies can mainly focus with the hospital level, with the consultant microbiologists and medical administrators involved for implementing those strategies in the Sri Lankan hospital setup. However, how antimicrobial resistance is an issue spread across many sectors, and active involvement is needed only in human health, not only human health, but also many other sectors. Unlike in human health, one of the major challenges we face all those sectors with regard to AMR is that there are no readily available AMR data generation systems. Awareness on AMR among many other sectors also considerably low. Therefore, significant financial and technical resources are required by those sectors to establish AMR surveillance and awareness. Within this background, we have set up a National Advisory Committee on Antimicrobial Resistance, incorporating participation of veterinary, fisheries, and agriculture and environmental sectors for multi-sectoral combined approach. But compared with to human health, many gaps have been identified those sectors. With this background, onset of the COVID-19 pandemic in 2019 has brought up unavoidable circumstances, causing some setback on progress of the activities pertinent to the AMR. Nearly all focuses physically as financial has been on control of COVID-19, causing many other important areas of work remain in the background. But as AMR could be considered as one of the equally, if not more important area of the work, it is my greatest pleasure to be part of this initiative on combating antimicrobial resistance. If not managed appropriately, the damage that antimicrobial resistance would cause to the health economy as well as the well-being of the community would have been more extensive than what we are facing currently. Thank you very much.
Okay, we now have a question that has come up. Can you hear me?
Yes.
Yes. It has come up from Dilip Liyanage. I mean, and as mentioned by Dr. Ratnayaka, what is the effect of COVID-19 on antimicrobial resistance? Maybe the UK perspective and the Sri Lankan perspective. The question here is, yes, COVID is a viral infection, but has that sort of impinged on made a greater consumption of antibiotics, or people are now more scared of infections and know something, and therefore it is less consumption of antibiotics? There is at the moment no clear data, but what would be the anecdotal information that Dr. Neil as well as Ms. Chalmers could give us, and then Shirani after that?
Of course, I think Dr. Shirani will explain because they are the clinicians.
Okay, so we'll let Dr. Neil come in first, and then Shirani, Dr. Chandrasiri will follow. Over to you, Dr. Neil.
Yeah, I mean, in the UK, COVID's had mixed effects, I think. In some of the larger teaching hospitals, I think their intensive care units have run into significant problems with multi-resistant gram-negatives, as their ICUs have been overrun with ventilated patients certainly in wave 1 and to a lesser extent in wave 2 in this country. And IPC practice had to undergo quite dramatic changes to cope with controlling COVID in that type of environment. So we did see some undesirable practices like double gloving come into use for a period of time, which appeared to allow some of the more resistant gram-negative organisms like Acinetobacter to potentially spread between patients. In York, which is a smaller teaching hospital, we certainly didn't have that level of pressure, and we were quite good at getting frontline clinicians lined up to take on a specialist role with COVID. And many of them were convinced by the evidence that bacterial superinfection was actually quite uncommon with COVID-19. And they started from a premise of, well, we'll try and avoid giving antibiotics to our sicker COVID patients unless there's some features that suggested a bacterial infection like unilateral disease as opposed to bilateral changes in the chest. And we did use procalcitonin measurements as a biomarker as well in wave 1 to try and restrict the use of antibiotics. And where we were using them, we were trying to stick to our community-acquired pneumonia policies, which use older drugs like benzyl penicillin rather than newer broad-spectrum antibiotics as our treatments, where we did opt for treatment in the minority of patients. So overall, our antibiotic usage didn't go up because we actually stopped doing a lot of other things like elective surgery, and other general medical practice went down, which probably compensated, or even in some cases overcompensated for our overuse, our general usage levels of antibiotics. So it's been a fairly mixed picture and certainly not a sort of catastrophic tidal wave of antibiotic use.
Okay, so in a sense, there's been some awareness of the problem. And then when COVID came, it was not a question of, okay, we got to do something emergency, do it. No, let's sit back and think carefully and use the information that we have carefully. And it's not been an avalanche of antibiotics and other drugs and so on. That's good. Anita, anything that you would like to add?
It is interesting that we seem to be using a lot less of piperacillin tazobactam, and people are not over-treating and over-diagnosing sepsis, and if they are starting antibiotics, they're more likely to use benzyl penicillin, which is our treatment for severe infection as opposed to sepsis. So I think that's quite a marked change actually compared to the behaviour we saw before that. We have audited the prescribing of patients with COVID and antibiotics, and what we found was just really reiterating what Neil said, was they were often started in our emergency rooms, but once they got to the admissions ward, they were very quickly stopped again. So that was also very satisfying to see those reviews and the stopping of antibiotics.
Okay, two important points there. One, even if they were starting off from the emergency room, the rational use kicked in the wards, and therefore the antibiotics were stopped. Secondly, as you demonstrated in your video, it was a sort of looking at the patient, focusing on the patient, and not on what is available and can be used. Narrow spectrum antibiotics into the patient rather than broad spectrum. I mean, I think this is something that we probably still haven't learned sufficiently in Sri Lanka. At the moment in Sri Lanka, it still appears that we give the broad spectrum antibiotics because they are more powerful and they are more guaranteed, etc. Doing the single narrow spectrum probably is not sort of, at the moment in favor. I speak as an outsider because I'm not in clinical practice, and I hand over to Dr. Shirani to tell me whether I am wrong or not. Go ahead, please, Dr. Shirani. Can you unmute your microphone and start?
Yes.
Yeah, we can hear you. Go ahead.
We are discussing about COVID and Sri Lanka. Our use of antibiotics actually has gone down. This is because less people come to the OPD because of the fear of COVID. And the treatment centers, we don't have that many patients ventilated for long durations. When we have patients ventilated for long durations, we get multi-resistant organisms. So I think we are yet to see the full impact of COVID. But at the moment, we don't have that much of antibiotic usage and resistance because of COVID patients.
Okay, that's something, in a sense, that's good, in the sense that we have a pandemic and we are actually using antibiotics rationally during a pandemic, rather than sort of, running and thinking, okay, we'll throw everything at it to get rid of it. Maybe something that has come out on that. Okay, any comments that the panel would like to make about the discussion and any other points?
I have one question.
Go ahead, go ahead.
It's from really Anita as well as from Shirani. Now, I think during the clinical ward round, I really raised this question with Anita. If somebody has got COVID-19 and not recovered fully after 10 days of time, I have seen antibiotics, especially amoxicillin, has been prescribed those patients if they have got chronic or they have got continuous cough. That is in the UK. But usually this type of diseases, the cough is not due to pneumonia, it's due to pneumonitis. So the place of antibiotic is really arguable at this point. That is for Anita. For the Shirani, I heard that for some antibiotics being used for COVID-19 patients, treatment centers in Sri Lanka, in terms of prevention of superinfection by bacteria or something else. So is it practicing, is it rational at this moment? So I had two questions, one from Anita and one from Shirani. Anita?
Just to say that obviously we discourage people for starting antibiotics, and we use we are guided by the white cells and the CRP just as part of normal clinical practice before we would be starting antibiotics. So I'm guessing your question is from primary care. In primary care, there are messages going out to the GPs. We have been reviewing our antibiotic formulary for the GPs to try and make sure that people are not starting medications and the antibiotics unnecessarily. I have read, and Neil might be able to comment on this, but there are some experiences that if patients are in hospital for a long time, they do develop hospital-acquired pneumonia, and they do develop sepsis with that. So obviously that has to be treated more aggressively. I wouldn't say that we have or are seeing a great deal of that, because piptazo prescribing is definitely an area that we focus in on, and we are using, as I say, compared to November last year, we're using less than half of the amount that we were using last year. So we're not seeing it in the hospital, but it is possible that it is happening in primary care. Hope that answers your question.
Anita, I got an answer from you, and I think these particular antibiotics being used at the primary care, since most of COVID-19 patients are being managed at home. So this amoxicillin for the COVID patient who has got continuous cough are being treated at the primary. All right, thank you very much. So Shirani, what is your experience over in Sri Lanka?
Actually, what you ask is about the treatment centers. One big problem is
the uncomplicated COVID-19 patients.
most of these treatment centers are not supported by microbiological facilities because lack of safety cabinets, technical staff is not doing that many sputum cultures. They are a bit afraid to do it. So I think most of them don't have guidance about what is going on in their patient. Because of that, they are starting antibiotics. But in Sri Lanka, I don't think they will start amoxicillin. They will start a bit higher level because almost all isolates are usually resistant to ampicillin in the ABST. So that might create problems in the future.
Okay, thank you.
Okay, we've got a question, which is sort of a very broad question, and in fact has been answered during the presentations, but I will repeat it, and maybe the panelists can add anything in addition to what they have mentioned. And it's a question by Lu Chen, who asks, what are the challenges of antibiotics control in UK and Sri Lanka? I mean, we've dwelt on that during the presentations. Probably to take the chance to ask Neil and Anita to say anything further that you would like to say on that.
Yeah, I mean, my belief is that even in the UK, where we certainly have reduced our overall antibiotic use as a country, the reductions, the bigger reductions have happened in agriculture and primary care practice, and not in the hospital sector where it's still going up, unfortunately. So the main challenge for me, it continues to be improving our diagnostics so that we can be better at distinguishing patients who are just unwell from other medical conditions as opposed to having infection. And that's where I think we need to put our biggest effort and get better at that. So combinations of biomarkers that actually identify a host that's responding to an infection as opposed to having heart failure or pulmonary embolism or whatever else that's making them very unwell. So we can target our treatments better. And just a general continued effort to raise awareness amongst all parties, both prescribing and consuming antibiotics, of the inevitable harms that we faced with them. These are not benign drugs, even though they are very cheap and easy to get hold of, and really deserve the respect and thought around their use that we devote to cancer chemotherapy drugs, which are also toxic and do harm. The contrast between the two types of chemotherapy, antimicrobial chemotherapy and cancer chemotherapy, couldn't be more stark, and I think we need to close the gap on that, because I think antimicrobials are equally toxic.
I was struck by a statement that you made, Neil, in which you said the cheapest thing is to use the drug. It is much more expensive to diagnose. It is much more expensive to actually identify the organism. Perhaps that's a question that we need to deal, an innovation. I mean, if you have a dipstick to say, yes, you are infected or not, and you have a dipstick which says, yes, it is E. coli or whatever it is, then you would then have an immediate roadmap on how to treat the patient. Maybe it's a question of whether the science will produce these answers to us before we do get overwhelmed with antibiotic resistance. Anita,
there's some
sorry.
in that discussion, isn't there? I mean, the contrary argument, I suppose, would be, are the antibiotics too cheap? Are we not paying the full cost of actually the harms they do? It's a bit like the polluter pays principle that we have in the UK. If you're going to use an antibiotic, you perhaps have to pay a surcharge for the privilege of using it that reflects the true costs of actually utilising it to the population as a whole.
Yeah. Anita, any quick comments?
So As I mentioned before, we are wanting to engage our clinicians, and we have had the support of the medical director and the board to develop, to encourage the different care groups and directorates to take ownership of antimicrobial stewardship, able to make improvements rather than us trying to impose something on people. We're doing it by motivating them to take an interest and do it themselves.
I was also interested in one of the statements that you said, that it was either you or Neil, which said that you had financial incentives as well as financial penalties.
Yes, I mean the so-called sequin initiatives in the NHS, which apply to hospitals, you can actually earn a certain amount of your income to the hospital by hitting appropriate targets for reducing either antibiotic use or the incidence of an infection like C. diff. And on the corollary of that is that if you go over your target, we at one point had a penalty scheme. So the hospital had to pay £10,000 for every patient above their threshold target that year. And they didn't get paid for the whole of that patient's actual care in the hospital as the tariff. The tariff was withdrawn for that patient and they got fined. So, I mean, I've been a microbiologist, since the mid-80s, 30 odd years. And for the first 20 years of that, between 1984 and 2004, we achieved quite a lot in terms of influencing our clinical colleagues, but there's no doubt that the introduction of top-down targets in the NHS was a sea change in terms of getting people to focus on things and actually start to do things. And we've made far more progress in the last 15 years, 14, 16 years, whatever, than we did in the previous 20 as a result. And commenting about your number of microbiologists in Sri Lanka, I mean, we've got 5 microbiologists for our trust alone. And we have a team of pharmacists as well, which Anita leads with colleagues. You really do need some boots on the ground if you're going to actually make real change in this arena, because you've got to influence all these frontline people, and because they're the ones that are prescribing. So the combination of a cohort of people on the ground doing the job and raising awareness, combined with some governmental initiatives, can be very powerful, I think.
Okay, over to Dr. Shirani. I mean, having looked at that, we in Sri Lanka have simply no method of incentives and sort of punishments or disincentives. Do you think that if we introduce something like that, maybe we would improve? If I can go slightly sideways, I'll give you a very quick example of what happened actually in Colombo in one particular hospital. This was the Lady Ridgeway Hospital, which was the biggest pediatric hospital in Colombo. And what the pharmacist used to do is, at the end of each month, he used to show the antibiotic consumption for the 7 wards in that hospital. And he used to paste it up, not on public notice board, but in the consultants' lounge. And when the consultants went in there, consultant number 1 then mocked consultant 3, saying, "You are at the top of the list. What is happening?" And the consultant number 3 then went and blackguarded all his juniors, and the antibiotics went down. So, I mean, this comparison worked, but after some time, you know, consultant number 3 again floated to the top. But I mean, some comparative data, would that be useful, you think, Shirani? Or anything that you want to say to try and achieve some amount of rationality?
I think National Hospital was using it for some time. I don't think they got any impact.
Oh, okay.
Because they make, I mean, for once or twice it will be okay, but after some time they make just excuses. We have higher number of admissions. We had these 2 bad patients like that. One thing we have is the wards are full. I mean, they have very overloaded wards. They want to discharge these patients as quickly as possible. So they start from the top thinking that it will help them to discharge the patient.
Okay.
Second thing is we need faith in antibiotics, that they should know that they are getting good quality antibiotics. Must bring that faith so that they don't need to prescribe 3-4 antibiotics. Finally, actually, in Sri Lanka, clinicians think it's like their birthright that they can prescribe. Microbiologists should not impinge on that type of attitude. So because of that, it might be a bit difficult to bring interventions to antibiotics which are not in red light zone at the moment. Red light antibiotics are not that much used except the oral antibiotics.
Okay, I mean, I agree with you on that. Clinicians think they are God Almighty and it's their birthright to do whatever they wanted, despite the fact that when we had arguments with them saying clinical pharmacologist of Chalmers is one of clinically qualified, they said, no, we are the clinicians. But would it be possible, Shirani, to sort of, do the monthly consumption of antibiotics in each of the wards in your hospital, also the number of patients that were there for the month? So there is some correlation. Well, if you used a lot of antibiotics, did you have a lot of admissions? Or why is it that you are the lowest in admissions, but you are the highest in antibiotic use? Any quick comment on that?
These wards are shared by more than one clinician. So it won't have much impact because they don't know whether it's their patients or their colleagues' patient. Only pharmacy can give according to the ward, not according to the consultant.
Okay, I see your point. Okay, right. So Ranga, all yours.
I have a question from Dr. Saman Ratnayaka.
Yes.
It's really, if I ask the same question from Saman, since he had been working as the Deputy Director General in Kandy National Hospital, Kandy, for a long time. And so he has a much interaction with the clinician, microbiologist, and the same setup. So,
yes.
My question is now, Shirani mentioned about the efficacy of antibiotics. There's not that much faith from the clinician side for the efficacy of antibiotics. Have you ever noticed sort of quality failure antibiotics in our health system? So have you taken out some quality failures of antibiotics or whatever from the system? And the same question would go to Anita also. How frequently you see quality failures in your system?
Yeah, shall I answer first?
Yeah.
Yes, now during my stay in Kandy, I have encountered many number of quality failure antibiotics brought forwarded by the consultant and microbiologist on 3 occasions I can remember. So, and this there is a way of passing the information to the medical supply division. So we did such a way, and then we stopped all batch of antibiotic using for our patient, which and then we pass the information to the Colombo.
All right. So how frequent it is? Is you get very frequently this type of incident, or
Not now, of course, not get frequently. My stay in National Hospital Kandy, I can remember only 3 occasions. To my knowledge, 3 occasions. Yeah.
Okay. Anita, what is your experience in terms of quality failure of antibiotics? Anita, are you there?
Yes, I'm here. Just to say that we have a lot of confidence in our antibiotics because of the system of regulation that we have for all drugs, not just antimicrobials. And that really evolved from the 1960s when there was the thalidomide disaster. In this country, that was really the start of regulation. Yeah, so I'm just saying from the 1960s, we developed much more regulation for all medications, not just antimicrobials, that they had to conform to certain standards to be able to be supplied, and we're quite tight on that. The manufacturers have to comply with the code of practice, and they are regularly audited and inspected. They have to supply a lot of assurance that the medication is effective, and so that is something that is quite tight. So I don't think we see failures of products that there might be in other countries, in other health systems. We have had problems with people because obviously drugs are quite expensive. People making false medications that are completely ineffective, and certainly within Europe, there's been there was a European directive to actually track each box of medication from the system, from the manufacturer to the wholesaler to the pharmacy, all the way through, to try and stop counterfeit medicines being put on the market. It hasn't been adopted here in the same way, and as I'm sure you're aware, we are leaving the EU on the 1st of January this year. That said, within the hospital, we take great pains to make sure that we only purchase medications from reputable wholesalers, and we, that have confidence in the supply chains, that we are not using substandard medications.
If I can come in here very quickly on the question of quality. I come in as one of the regulators because I was a regulator in Sri Lanka, and I was the CEO of the National Medicines Regulatory Authority. This is a question that comes up frequently. But there are 2 or 3 steps on the way. First of all, our pharmacists are able to identify if the products, by just looking at them to see whether they are of, there is a problem. There is probably precipitates in a vial, or the tablets or capsules are discolored. So that's the first one. So that type of thing prevents things that have a very obvious problems being given to the patient. But the second one is a more important one that Dr. Ratnayaka said, that a clinician comes and says, look, we've used this medicine, we've used this antibiotic, and generally the patients have responded, but with this batch, they are not responding. Is it because the antibiotic is of poor quality, or there are other factors? The answer to that is to actually send the samples off to the quality National Drug Quality Assurance Laboratory that is in the regulatory authority. And what have been the answers that we have got from that? The answers we have got when poor quality has been reported in terms of there is no problem macroscopically, but we've sent it to see whether the other factors are there, has been, yes, there have been a few where there has been either the dissolution didn't work out quite well or something. But on the other hand, when we've looked at what about the active component, there's supposed to be 250 and there is a leeway of 5%. What's the correct active component there? And most of the time, the active component was there or may have been slightly less, may have been 6% less. So in that sense, in a country that has a reputation for checking for quality, that in itself will decrease the number of substandard quality medicines. As for the final one that Anita mentioned about false medicines, we haven't had that much so far. I do not know the reason, but that's something we've looked for, and there have not been falsified counterfeit medicines. Okay. Well, we've just got a late-breaking question from Sri Lanka, which says, in Sri Lanka, antibiotics can be bought over the counter. I add, yes, but that is not allowed according to the regulation, but we acknowledge that it happens. And how do you assess the resistance without knowing the dosage? Quite an important point. If you wanted, if you were given only 2 days supply of an antibiotic, when you are supposed to take it for 5 days, you didn't get 5 days supply because you didn't have the money, or the pharmacist gave you 2 days supply because if he insisted on 5 days supply, you might have not bought it. So can you therefore promote resistance? Well, the answer is yes. But the question is, what do we do about what I would call, we call it the under-the-counter prescribing of antibiotics, not only antibiotics, other medicines. That is not a question that we can answer now, and will take much more in regulation for it to be answered. People ask this question, why can't you do this in pharmacies? What one must remember is that regulation in general must improve in the country for all this to come about. If you go and look at public transport in the United Kingdom, the buses are all clearly clean, well regulated and checked. If you look at the buses in Sri Lanka, some of them have bald tires, may not have the required equipment. So now, in that sense, public transport is poorly regulated. And that's a manifestation of the general poor regulation that is there in low and middle income countries. Quick final questions before I pass it on to this one, before I pass it on to Dr. Dolamulla for the concluding points. Any other questions, or shall I conclude? Okay, during this seminar, we've gone a distance from very intricate, carefully monitored antibiotic use in the United Kingdom, going through and medicines information being provided so that the antibiotics can be used well. And then we've gone on to Sri Lanka, where what we have there is high-level global strategic plans, but as mentioned, very inadequate resources to do that. It was mentioned that 800,000 people in the area, York Area Trust, had 5 clinical microbiologists, whereas in Sri Lanka, with a population of 20 million, we have only 45 clinical microbiologists. So what is being done within this huge range spectrum of issues that are there? Well, we can clearly see that there is some achievement in the United Kingdom. in the clinical use, but as mentioned, the majority of it was outside clinical use that is being controlled. Back to Sri Lanka, the clinical use, sadly, is not very well regulated. In a sense, there is some regulation. You will not abuse the expensive antibiotics because the cost of it is too high. So in that sense, it's a self-regulating this thing. What information do we have on use of antibiotics outside the human healthcare system? As mentioned, they are stopped as growth promoters. So in that sense, there is action on that area also. So in conclusion, antimicrobial resistance, as was mentioned, is a global problem, and therefore efforts to contain it, to improve public health, have to continue. It is a constant battle. Even in well-resourced countries, there are situations where further progress is needed. In poorly resourced countries, clearly we need more resources, but also as importantly, commitment to do what is correct, and therefore to achieve the full potential of antibiotics so that we can preserve it for future generations. Thank you, and over to you, Suranga.
Thank you, Professor Krishant. To sum up this event, I would like to thank all the current and future participants, since we would have a recorded version immediately, and further all the panelists, including Neil, Shirani, Anita, and even Professor Krishant. And I can see how busy Dr. Saman Ratnag now only is going home, and it's about 8:30 p.m. in Sri Lanka. Further, I would like to extend my sincere gratitude to following persons and institutions. Firstly, Professor Sanjay Bhattacharya is the Director, Center for Global Health Histories, University of York, UK. Then Anap Chakraborty and Steve Parker for the administrative and IT support. Then our partner organization, University of York, World Health Organization, Regional Office, Europe. At last but not least, the Wellcome Trust, a global education charity based in the UK, for their generous funding support for this event series. Thank you very much. And let me wind up this session saying good afternoon and good evening for everyone.